Good day. My name is Imelda Williams. This presentation will focus on abnormal appearances of the pelvic girdle and the lower limb. I've separated the presentation into three parts. Part A will focus on the pelvis and the hips. Part B will be on the femur, the knee, and the lower leg. And Part C will be on the ankle and the foot. This presentation is focused on learning outcomes 3 and 4, and I trust that at the end of the sessions, you'll be able to apply logical method when you interpret normal and abnormal appearances of the lower limbs and the pelvis, especially in the emergency and trauma context. I also hope that you'll be able to generate informed opinions about radiographic images of common conditions and in particular fractures, as well as identifying pediatric considerations for the lower limb and pelvic girdle. So at the conclusion of this lecture, and specific to Part A, I hope you'll be confident in identifying also the radiographic anatomy, the normal variants, as well as common fractures and dislocations and common pathologies that's related to the lower limb and the pelvis. I've given all of the references for all three presentations in the slide. So there's a couple of references. It's the book by Bontrager and chapters 6 and 7, and then in Chan there's chapters 5, 6, 7, and 16. And in Raby, there's chapters 14, 15, 16, and 17. And then in the image interpretation manual, I've given all the pages related to the pelvis and the lower limb. In addition, I've given some recommended references, and in particular, the one like Greenspan and Beltram, I've been using some of those resources. Please remember, you don't need to use all of those sources. It's just that I make it available as you have got electronic access to the e-resources. The Royal Australian and New Zealand College of Radiologists, RANZCA, has developed clinical decision rules. They've also provided a number of specific modules. This is done to assist clinicians in deciding whether a patient should be referred for diagnostic imaging. And for this week, we will include the following: an introduction to CDR, the module on pediatric ankle trauma, as well as a module on adult ankle trauma. I've also included some radiographic images to test your radiographic anatomy, so I would encourage you to complete this. I will give feedback on all of the radiographic anatomy labels when I give feedback on the practice bank. And here I've included a lateral hip view with the radiographic X-ray image to test your knowledge. With the pelvis, it's important to differentiate whether you are looking at a female or a male pelvis, and the biggest differentiation is when you look at the subpubic arc. In the female pelvis, it's greater than 90 degrees, so it's obtuse, and because of that, the ischial spines are wider, the circular pelvic inlet is wider, and the sacrum is less curved. For the male pelvis, which is narrower and deeper, the subpubic arc is less than 90 degrees, so it has an acute angle. And on X-rays, you will find that the ischial spines are much closer, and also you have the inlet is more oval or heart-shaped, and the sacrum is more curved. There are a number of radiographic lines to help you assess the pelvis. Firstly, there's Shenton's line, and this is a gentle curve from the lower border of the superior pubic ramus and the inferior border of the femoral neck. Then we have the teardrop sign, which forms the medial wall of the acetabulum. There's also the iliopubic or iliopectineal line, which forms the anterior column of the acetabulum, and then the ilioischial line, which forms the posterior column of the acetabulum. So referring to Shenton's line, here you can see that it's the gentle curve from the pubic ramus, or you could follow it from the superior border of the obturator foramen, and it should form a gentle curve with the neck of the femur. In the image on the left side, you'll be able to see that, that there is a jump from the curve to the femoral neck, which indicates that there is a dislocation. The image on the right indicates the teardrop sign, which is also called Kohler's teardrop. It's important to look at the sacral foramina, and on the pelvis this appears as curved white lines, as such as the purple arrow shows, and they should align, the right side should align with the left side, and if there's any disruption to that alignment, it indicates that there has been a vertical displacement or that there is a fracture. The next image shows the iliopectineal line, which forms the anterior column. We have the ilioischial line, which forms the posterior column, and then we have also the anterior wall. I've given another slide here of an X-ray image, and I would encourage you to try and complete that one as well, which shows some of the lines that I have mentioned. Now moving on to the ABC search strategy, there's a number of areas that needs to be checked for alignment. So within the pelvis you have 3 bony rings, and if you have a ring-like structure, if there's one fracture in the ring, then frequently it's associated with either another fracture or a dislocation. Secondly, look at Shenton's line so that you can determine whether there is any dislocation or subluxation of the hip joint. It's important to also compare the SI joints. They should be equal in width. And then if we look at the symphysis pubis, the superior border of the pubic rami should align, with the width of the joint should be approximately 5 mm. And I've mentioned the sacral foramina, so if there's any disruption to the arcuate lines, that indicates a sacral fracture. And then very important is to look at the acetabulum and compare both sides. It can be very difficult on plain X-rays to see whether there's fractures in the acetabulum, but if there's any high suspicion, then CT would be indicated. Now moving to the bone, trace the outline of each bone so that you can see if there's any steps in the cortex, and also look for any changes in density, whether either reduce or increase, which will affect the trabecular patterns. And with the joints, need to check that the joint spaces are uniform. Search strategies for soft tissue is to look for the displacement of soft tissue outline. So for example, the perivesical fat plate, which is suggestive of a hematoma secondary to a fracture. Also soft tissue calcifications, phlebolytes, artifacts, foreign bodies, and then apophyseal avulsion fractures. So satisfaction of searching the pelvis is really important. If you find one abnormality, you need to search for the possibility of another abnormality. Pelvic fractures are relatively uncommon. The pelvic ring has no inherent stability, and it's very dependent on ligamentous support. Fractures can be classified as minor, and they tend to be stable, isolated fractures, or major, unstable, displaced fractures. So when fractures involve the bony rings, look out for signs of a widened SI joint. Diastasis of the pubic symphysis represents a fracture of the main ring, and then look for any double pathologies, for example, fracture with dislocation, as that is equal to an unstable fracture. And as mentioned, satisfaction of search is extremely important in the pelvis. So here you can see the pelvis is like a stable ring structure, and it contains the 3 bony rings. So you have the inlet, and then you have the rings formed by the obturator foramen. Fractures around the ring which do not break into the ring is classified as stable fractures. Normally it's the result of moderate forces. So commonly it includes unilateral fractures of the pubic rami or isolated sacrum fractures. With sacrum fractures, the mechanism is usually a fall onto the sacrum, and these fractures tend to be transverse in comparison to major trauma where fractures are vertical. Here we've got examples of stable pelvic fractures and fractures of the iliac wing, and then also isolated fractures of the ischial tuberosity, transverse fractures of the sacrum, and then unilateral single fractures of the pubic rami. Unstable pelvic fractures consist of fractures to both arcs. There is a very high risk of hemorrhage, and these fractures are classified according to the mechanism of injury. And here I'm going to use Young's classification. So if the mechanism of injury is from the lateral side where you have lateral compression, that is the most common and it's called a lateral compression fracture. If it's from the front, it's an anterior compression fracture. And you could have vertical shearing, and then you could have complex combination of rotations. So Malgain has classification of unstable pelvic fractures, and these involves unilateral ischiopubic rami, so with the disruption also with the SI joint, and then fractures through the sacral wing and the pubic rami, or fractures through the ilium. The straddle fractures involves both of the obturator rings, and they tend to be often comminuted. Bucket handle fractures involves unilateral ischiopubic fractures, rami with fractures about the disruption of the contralateral sacroiliac joint. And then dislocations, these can be unilateral, or you could have bilateral where you have a sprung pelvis, so where the pubic symphysis is widened, so you've got diastasis of the pubic symphysis. So lateral compression is most commonly an unstable fracture. It affects the iliac wing as it folds inward. So when we compare on this image the SI joint on the right to the left, we can see there's a difference in terms of the width. It also creates possible fractures of the pubic rami as well as the sacral foramina. Sometimes you could have central dislocation of the femoral head, which can also result in a crush fracture of the neck of femur. With apicompression, there's progressive widening of the symphysis pubis because of tension on the SI joints. It's possible to have up to 2.5 centimeter separation of the symphysis without disrupting the posterior ligaments. There tend to be associated vertical fractures of the pubic rami, and this type of compression can cause vertical and rotational instability, as well as posterior femoral head dislocation and posterior rim fractures. Vertical shear fractures are uncommon. The mechanism of injury tends to be fall from a height onto extended legs or a heavy weight on shoulders. This results in disruption of the anterior and posterior sacroiliac ligaments and can cause fractures through the pubic rami, as well as vertical fractures of the sacrum and disruption of the SI joint. There could be superior placement of large hemipelvic fragments and severe ligamentous disruption and gross instability. It's important to remember that the iliolumbar ligament attaches to L5 transverse process, and it results in a fracture of the tip of L5, which causes vertical instability. So examples of unstable fractures, here we can see there's double fractures of the pubic rami, and then also we can see through the SI joint as well. And then this image is that of vertical shearing as well as diastasis of the symphysis pubis, and this is a complex forces on the pelvis and resulting in severe injury to the pelvis. So with complex combined fractures, it's a combination of forces, and the patterns of injury can vary, but the fractures are inherently unstable. And now moving on to acetabulum fractures. These fractures can be comminuted. Important to remember that bone fragments can be trapped within the joint, and therefore CT is important to exclude any bone fragments, and this can result in premature degenerative changes. It's important to use those landmarks which I've mentioned to assess for acetabular fractures, and these are the iliopubic line as well as the ilioischial line. Acetabular fractures can have classifications as well, and in the image on the top left we have fractures involving the anterior iliopubic column, and then we have the posterior iliopubic ischial column. We could also have fractures involving both of the columns in a transverse direction, as well as complex fractures which can be either T-shaped or stellate. And here we can see on the right side that the column has been disturbed of the acetabulum area. Hemorrhage can cause up to 10 to 20% of mortality in pelvic fractures, and the reason being that the superior gluteal artery can be commonly injured in posterior pelvic fractures. In addition, the obturator and pudendal arteries can be involved in pubic rami fractures, and the retroperitoneum can hold up to double the volume of blood with diastasis of the pelvic bone. All of the above can result in associated morbidity and mortality. Now, in the unfused apophysis, in the unfused pelvis, apophysis represents sites of muscle insertion. These are common sites for avulsion fractures, especially in young adults. The main ones that appear by puberty and fused by age 25, and these are the anterior inferior iliac spine, and the rectus femoris attaches there. The iliac crest, we have the abdominal muscles that attaches, and then the ischial tubercle has the hamstring, which is quite a common injury, and then the anterior superior iliac spine has the sartorius that inserts there. Now I've given the next slide, which shows the muscle that inserts and also to which anatomical area of the pelvis. So here we can see the ASIS and it's the sartorius, and also here we have very commonly the ischial tuberosity with a hamstring that attaches there. In this slide, we have an ischial tuberosity avulsion following a hamstring injury that was not diagnosed initially, and this now shows a very florid and very dense calcification in the area as the bone starts to heal, and this could have, in future, could have quite a high bit of morbidity for the patient. This example is a patient who had an ASIS avulsion, and this was in a soccer player, and then commonly in tennis players, because of the serving action, you could have iliac crest avulsions. Now when we move on to the hip, the main thing is to determine whether a fracture is intracapsular or whether it is extracapsular. And also to remember, in the elderly population, that it is associated with high morbidity as well as mortality. Intercapsular fractures includes the subcapital and transcervical fractures. Of course, there is a risk of reduced blood supply and avascular necrosis. With extracapsular fractures, these occur at the level of the trochanter, so intertrochanteric or below, so subtrochanteric, and it does not interfere with the femoral head blood supply. Gardner's classification can be used for hip fractures, and in the image on the top left we have a subcapital neck fracture and then a transcervical fracture. So these fractures will interfere with the blood supply to the femoral head. And then the intertrochanteric fractures, which is extracapsular, subtrochanteric, and then the trochanters, the greater as well as the lesser trochanters, can also fracture. Intracapsular fractures can be classified according to Powell's classification, and it is based on the obliquity of the fracture line, and the more vertical that line is, the more unstable the fracture will be. Intertrochanteric fractures generally occur in the older age group. There tends to be less displacement, which means there's less rotation of the patient's leg, and quite often there is less suspicion of a fracture. So on this image on the left side, we can see a lucency that runs just at the level or just below the level of the trochanters. There's a classification as well of intertrochanteric fractures as 2-part or 3-part or 4-part or multi-part, so depending on the various comminutions. And then important on X-rays is also to look at the angle between the femoral shaft and the neck. So the normal angle should be between 125 to 135. In varus deformity, this angle is decreased to 90 degrees, and then in valgus deformity, this angle increases to 150 degrees. Now, hip dislocations can be anterior, posterior, or central due to trauma. You could also have congenital dislocations, and then a slipped capital upper femoral epiphysis or SUF. Patients with hip dislocations are prone to avascular necrosis and degenerative arthritis. Some of the complications with SUF is it can result in sciatic nerve palsy, avascular necrosis of the femoral head, osteoarthritis, and then with the femoral head, neck of femur or shaft fractures. This is in major trauma, there is a risk to these areas. The posterior hip dislocation is more common, as the patients would present with internal rotation of the knee, and it's important to note that in 90% of cases there could be associated acetabular posterior rim fractures. The position of the femoral head in the posterior dislocation tends to be superior and more laterally, and about 20% can result in avascular necrosis. With anterior dislocation, which is less common, this is caused by violent abduction. The patient normally presents with the knee in external rotation. The femoral head tends to be depressed inferiorly and more towards the middle. And then there's an association of femoral head fractures in about 75% of cases. Lecalvi-Perthes disease is because of osteochondrosis of the hip, and it follows avascular necrosis of the femoral epiphyses. There's a higher male preponderance of 4:1, and the age groups that it occurs in is around about 2 to 12 years. So what you need to look for in radiographic findings in the early stages, the femoral capital becomes smaller with some subchondral lucencies, and then in late stages you would see fragmentation, flattening, and sclerosis of the femoral capital epiphyses. So on the X-ray that we have here, if you compare the right hip to the left, you can see on the right side that you've got this late fragmentation and sclerotic appearance of the femoral head. Now, with a slipped upper femoral epiphyses, this is associated with obesity, and about 20% can be bilateral. It also has a male preponderance of 3 to 1 and sits within the age group of 10 to 15 years. So if we look at this X-ray, Klein's line is drawn along the superior border of the femoral neck, and it needs to intersect with the epiphyses. However, on the image on the right, we can see that it misses the epiphyses, and this is also called, it has this appearance of an ice cream cone that has slipped off, and this is typical of a Salter-Harris type 1 injury. This concludes part A. So once you've worked through this, I would encourage you then to move on to part B. Thank you.